No, please.
We're on.
Oh, Wentz fumbled. It's bad for the fantasy.
All right, guys.
We're live today.
We are. Just come on. You guys, good evening.
Good evening.
Good evening, everybody. We're back with the sports doc. Somebody has their volume on their mic louder, so we're getting some feedback.
How's that?
That's better.
Sweet.
All right. I think, can everybody hear me?
I can hear you.
I can.
All right, guys. Well, we're back with the sports doc. I'm Dr. Rob Palumbo from OAA Orthopedic Specialist and OAA Sports Medicine Foundation. And we have two great co-hosts today. One is Howie Knudsen, all-star physical therapist from St. Luke's Hospital System. And we have Mark Miller, ATC, PTA, MOUSC. You know, he's got a lot of things going on. But
I've been to school a lot.
And so we're gonna be going over a lot of the injury reports from this week from the NFL and from Major League Baseball, maybe. And so why don't we start off with Mark? What do you got?
We always got to start off with football season.
Okay.
So I think that the biggest injury of the week, obviously, that most of people want to hear about is the Saquon Barkley injury. Some of the things that we like to do here on our podcast, what we used to do on the radio show, we like to use the injuries in the world of pro sports to kind of educate people. There's a lot of stuff that goes on from the media perspective, and you hear the reports in the media about injuries themselves and how those injuries are progressing. And we hope to give you a little bit of more inside information about what the real reports of what's probably going on. So Saquon Barkley obviously left in the first quarter, I believe, of that fantastic game with the Tampa Bay Buccaneers with an ankle injury. Obviously, Dr. Palumbo, the New York Giants are near and dear to your heart. Unfortunately, they've been. By the way, I didn't know that the Giants drafted Eli Manning again with the sixth pick in last year's draft. So
He moves better than Eli.
He does. He moves better than Eli. But I swear to God, he talks like him.
Exactly.
He looks like him. He even looks like him in a uniform.
Yep.
So
I think he
needs to make those faces.
Easy, big guy. I know the Eagles are on tonight. I get it.
I don't care. I don't care if the Eagles are on. That is definitely not a concern of mine. My guys are 3-0. I'm the 3-0 team in this group right here.
That's true. That's true. My team.
You know what, Mark? I have the ability to mute him. So let's talk a little about the syndesmosis injury and the high ankle sprain.
High ankle sprain.
You know what? Before we get into that, can I bring up something? So somebody brought up something very interesting to me about this injury. Did you see the play before he sprained his ankle?
I don't recall.
He took a really big hit. He came out of the game. He went in the tent. He popped out of the tent in about 10 seconds. He got back in the game, and then he sprained his ankle. So I know this research.
Was it looked like a knee?
No, it looked like it was, possible concussion or, he took a big hit.
Okay.
And they checked him, took him out, took him in, and then he hurts himself. I know there's research coming out that is along the lines of if you are concussed, you are at a higher risk for orthopedic injury following that event. It just is something interesting. And it was a Giants fan brought it up. I thought, maybe it has some validity.
Listen, that is obviously they have to go through the concussion protocol. It's very strict. There's actually in that tent, there's usually a non-team physician there. One of the psychoneurologists that are qualified by the NFL. And so they went through all the tests. Now, obviously,
Oh, sure.
it's not a complete, it's not like going to get an evaluation at a neuropsych, neuromotor physical therapy. So you're not going to see everything, but it's a good thought, Howie. I mean, certainly reaction times in a true concussion, reaction times go down, and so it could have happened. However, from what I remember from the actual injury, is that the mechanism was there, and
Sure.
it's not like he misstepped. It was part of the actual the tackle and the actual play. And why this is so different from your normal ankle sprain, which is usually your foot rolls underneath your ankle. This is where your ankle actually rotates outward, and it's so much more of an injury. And let me show you a little bit of what I'm talking about. So let's see if we can. I'm gonna share the screen so you guys could talk about it as well. So you tell me. Okay, so you guys see that, right?
Yep.
Yes,
right,
sir.
So what we're looking at, so if this is the ankle, okay, so you have the, and don't look at this right now, but if you look at the tibia, fibula, and the talus here, now what they're showing is that there's a little space in between this bone and it's different from the space there. That's a sign of an injury. Now you see this fracture here. What happened is this bone rotated into this bone and made a fracture here. This is what happens when you complete that. This, again, you rotated this ankle out. The fibula went with the talus. Now, this is what you got to remember. There's an incredibly thick ligament right here, and it goes all the way up. But the really stout part of that ligament is right here, and it's called the syndesmotic ligament. And to tear that takes a lot of energy to tear that, much more than tearing these lateral ankle ligaments over here. So that's why it becomes a much more significant injury, because it took more energy. It took more energy to create it, number one. Number two is that if you think about when you sprain your ankle, and it's usually over on this area, you could wear a brace or a tape that stops your foot from going underneath. Okay, it works pretty well. The problem is with this, there's no brace that's going to stop you from rotating your foot out and with any significance. And so it's impossible to really splint. And that's one of the problems with it. So, if you remember some of the other, here we go. So let me go back here. Back. Oh, it's not letting me do it. But what we're talking about is, so that ligament is a much stouter ligament, and one we got to worry about. And I know you guys, I diagnose this, you guys treat it. So I mean,
Great.
This is one of those deals where you have to identify very quickly, and it's pretty easy you just rotate that guy's foot out and it's going to hurt. And what we know is the amount of distance from the ankle joint up the leg that syndesmosis ligament is painful. Well, you can actually grade the injury that way. And so the fact that he's not having surgery, at least I know, and I know it was a consideration, but the reason why he's not having surgery is that enough of that ligament is intact that as long as they protect him, he should be okay. But Mark, you're on the field, you've been an athletic trainer at college level. This is something you used to see all the time. Try to explain why we can't brace them the same way as a regular ankle sprain.
So the most difficult part of a syndesmotic injury or a high ankle sprain is that once you get into a dorsiflexed position. So if our ankle looks like this is plantar flexion, you're pointing your toe like a dancer would, and this is dorsiflexion, bringing your ankle back. As you can see where those two bones are, when you bring your foot back into dorsiflexion, it spreads those two bones apart, therefore putting stress on the ligament. Well, what is sports? Sports is all into that dorsiflexed position, pushing off and driving. So not only any time that we get into a stressed position where he is going to dorsiflex his foot forcefully into that position and spread those two bones apart, pushing off, cutting, any sort of rotational, getting hit from the front and trying to drive forward and push someone back. There's no way to officially limit that position. And there's no tape or brace you're going to get on someone that is going to limit the amount of stress in between those two bones. Now, we have tactics once he gets better. There's different taping techniques that we use to try to keep those bones together and give it a little bit more stability, trying to create a faux, using tape to create like a faux brace across the bones. We've used, in the past, I've known athletic trainers that have used Elasticon, which is a really thick tape, and they literally just tape the leg straight around, and they're trying to draw the tibia and the fibula together. And the Elasticon stretches a little bit. Right. No, exactly. You got to be careful that you don't cut up, feeling to the foot. There's some pretty important stuff that's running, through that area as well. So, but that Elasticon does have a little stretch and give to it. And you can kind of determine how much stretch and give you want to give to it. There's also other, go ahead.
But the ligament itself needs to be in continuity.
Yes.
Or it can't be separated fibers at that point, because there's no amount of taping that you can do that can resist the actual shear forces the body weight's going to put on, the rotational forces.
And the other thing to think about is, from a biomechanical standpoint, is dorsiflexion is the most stable position of the ankle.
Mm-hmm. Oh.
And plantar flat in a regular ankle taping, you're protecting against that unstable position. So, you're eliminating that most stable position, the ankle.
Exactly. So, when it goes to like its most significant, and it's more of a separation than any fracture of the bone. This is what you'll see, and this is what was contemplated at the time. And let me show it to you guys. Let's see, a comment should. There we go. So if you look at this, all right, this is actually what we do in surgery. We use this device. Now it looks like it's on the outside, but it's actually going through the bone over here and through the bone. So tunnel here, tunnel across, tunnel across. This is a little bit of an older configuration, but you get the idea that you're using this really strong tape. I mean, this tape you could basically play on that tape. And so if this was probably closer to play and they were chance of playoffs, this may have been the configuration they were talking about.
So is that what they did for Alabama's quarterback prior to the national championship game?
Exactly. Now there was a little plate over here that they put everything through, but in general, yes, that's exactly what they did for him. So, but did the tear go all the way up here? I don't know. Was it just more of a grade 2 than a grade 1? I don't know. But certainly this stabilized it enough where he was able to move on that pretty quickly.
Now he was back in 2 weeks, I think, when they did that surgery.
Exactly. Yeah. So, I mean, you are depending on the failure strength of that fixation device, but it obviously worked.
Sure. And he hasn't had any lingering effects, because it doesn't seem to be limited at all now. So definitely successful.
No doubt.
I thought they might do that surgery because it seems like it would decrease rehab time
very quickly. But there's an old saying, Howie, nothing so bad surgery can't make worse.
Yes.
So
right. I say that to patients all the time. They ask me about surgery, and I use your quote all the time.
I'll tell you, if a doctor ever says 100% guarantee, get out of the office.
Now that line we both learned from you, and you got that line all the way back when you were in residency.
That was Dr. Joe Leddy, one of my mentors, one of the most important people in my life. But he he had a lot of them. Some of them I can't say on the podcast. A lot of really good information. It was great. So that was one of them for sure.
And the thing, like, we start talking about once he gets stable, some of the problems that we have from a rehabilitation standpoint with a high ankle sprain, especially in someone like Saquon Barkley, is that in an offensive lineman, usually once they start healing up and they get more stable, we get scarring into that ligament, and like how we said, in that dorsiflex position, we get more stability. They are not cutting and driving off of it. They're not getting a ton of rotation out of that joint on a snap to snap basis. Whereas Saquon, obviously, he needs that explosion. He depends upon it. He depends on the explosion to protect himself. He depends on an explosion to change directions and be as valuable of a football player as he is. And that's what makes him special. The issue is once we start getting him stable, now we start to deal with stiffness issues. So if we can get his range of motion early and we can do it safely, that's great. But then a lot of times what will happen is 3 to 4 weeks into these injuries, they start to really, really stiffen up. And that's a really
because
it's a game to play, because you got to give them more motion, but you have to do it safely.
Right. It's a catch-22.
Talking about bringing the ankle up, though, what we call dorsiflexion, you're putting stress on a ligament that you don't want to put stress on.
Sure.
So this is where a lot of times we'll talk about distracting the joint to keep the capsule loose, to mobilize it away from the bone, where you guys have to do all that manual work. It's not something they could do on their own. This is a lot safer. This is the guy you'll put in the pool, or how you pull in the Alta G, which is basically a treadmill that there's underwater treadmills, and then there's air pocket treadmills that kind of support you. And that's what you want to do. You want to unload it. So they'll be keeping them fit, no question about it. It's just harder because you never want these guys to get their toe caught on anything and externally rotate, because that could exacerbate the injury, certainly prolong healing, and it hurts like a son of a gun.
Well, let's go back to the dorsiflexion issue. So we want to limit dorsiflexion, but if you don't get full dorsiflexion back prior to him going back to play, then you're going to be significantly limited. And it also puts the ankle in an unstable position if you don't get full dorsiflexion. So, it's right. It's a difficult thing. You're sort of double-edged sword. You want to get motion, but you don't want to get motion. So you just have to really know when you're doing rehab on something like this, you have to know what tension you're putting on the tissues.
And that's why it's an art.
You know when to push it and pull back. It's tricky.
That's exactly right, Howie. That's very important. Very important. So,
then when we examine this, in the layman's terms, the media terms, they have now changed the vernacular from a high ankle sprain, and they'll refer to it as a high ankle sprain, and then they'll refer to it as a low ankle sprain. Whereas, the common low ankle sprain, the most common low ankle sprain would be that to the anterior talofibular ligament, which is, a much smaller ligament. That's your typical inversion injury, where a player will come in and they say, I rolled my ankle. That's the typical injury that we would see there. Now, interestingly enough, the way we used to manage these injuries back, I hate to say this now, but, being my age, I can say back in my day.
I wish I was your age.
Which is the reason that I limp pretty much most often, or every time I go mow the grass, my ankle swells. Back in the 80s and early 90s, we used to manage these injuries when you'd roll your ankle. We'd try to get the swelling out of your ankle as fast as we possibly could. We wouldn't immobilize the injury. Maybe you'd get an air cast, maybe some compression with a horseshoe and an ace bandage, trying to get the swelling out of there. And then, you kind of suck it up and you rehab and play at the same time. But what I think we learned now, and as we deal with these ankle injuries more, it's not uncommon in today's terms to have an inversion sprain to that anterior talofibular ligament, where you're going to go into an orthopedic boot for a period of time. The great thing about the orthopedic boot is you can take it off and do rehab while you're using it, but you can go back into a stable, immobilized position. It keeps you in that dorsiflexed position while you're in the boot. And we know that we need to let that ligament scar in and heal in. If you would examine my ankles, the amount of inversion that I have, or the amount of supination that I have, which is a combination of those motions, is way too much. It's far too much. And
you mean the fact that your fibula could touch the ground?
That's exactly correct. Yes, and I could probably do it from a standing position. And the amount of arthritic changes that have occurred in there, due to that lack of the ligament being there from the multiple injuries I've sustained to my right and my left ankle, it makes things a little bit more challenging at 42 than I should really feel. But and that's not to say for lack of trying the rehabilitation that I've tried to do on myself. When the ligament's not there, it's not there, and it's going to create increased motion in those joints. So it's just a sprain. I like to say that all the time. That's not a term that we should use anymore, because it does create a lot more issue. There's a great picture of it.
Here's the typical sprain where you invert your foot, you roll it in, and then the most important ligaments are the calcaneal-fibula ligament that goes from the fibula to the calcaneus over here, and the anterior talofibular ligament over here. The anterior tibial fibular ligament is really the start of the syndesmotic ligament, and that's what the difference is. But again, you could use a brace and stabilize your foot from rolling.
Correct.
Much more easily than you can rotating that out.
And I think one of the big things is the lessons that we've learned too. I had a mentor of mine at Carnegie Mellon that our team physician used to say all the time. He's like, just because it's sports medicine doesn't mean it's always the best medicine. And we've learned that these don't necessarily aren't. We're back in our day, all three of us. You roll your ankle, you tape it, and you brace it, and you go play, and you deal with it. And we learn now that we need to probably take a step back a little bit on these. We need to control the swelling, but not be crazy about it. That swelling is occurring for a reason. And we need to allow some, if there is translation, if we can see a range of motion difference because that ligament has been, a grade 2 or a grade 3, we need to take it a little bit slower and let that scar in, because down the line, and I don't mean years down the line, I mean, later on in that athlete's season, that instability is just going to get worse, and it's really not going to get better.
Exactly. So what else do we got, babes?
Well, now that we've gone into the world of high ankle sprains, let's stay down in the foot. As aptly predicted last week, the Cam Newton saga continues. It was funny last week how Dr. Palumbo and I talked about Cam Newton's injury, and he had a foot sprain that he sustained during the preseason that kept him out most of the preseason. He's been noticeably aggravated on that foot since the season has started. And then after the week 2 game, he had re-aggravated the injury, and they were going to hold him out of last week's game, and in hopes that it would give him a little bit more rest time for this week. Well, Kyle Allen goes out, plays well, and now it's come out that, he may have a Liz Frank injury. Yeah. Well, here on this podcast, we're just going to go ahead and say that, like last week, he had a Liz Frank injury, and trying to play on that is definitely admirable. But for a player that does what he does, it's probably not going to be the most efficient. And I'm wondering how long it's going to be until we hear, if Kyle Allen comes out and has another game, I wonder if we're going to hear that Cam Newton is shutting it down for the rest of the season.
Exactly.
Well, you're taking away the guy's base. I mean, he needs a base to push off. He needs a base to run. We just talked about that syndesmotic injury and not being able to push off. I mean, it's similar kind of biomechanics, and if that goes from a Liz Frank sprain to a Liz Frank fracture, I mean, he's in big trouble.
No doubt. No doubt. I'm trying to bring up the Liz Frank injury, and for some reason it's not letting me do it. There we go. So again, what we're talking about is this joint between the metatarsal bones and these tarsal bones over here, and that again, that ligament goes between these two bones over here. And if you split it, this is like early, but then this is late, and you can actually see a little avulsion fleck over here as well. So that's obviously something you got to really worry about when you're talking about these injuries. And again, what we're talking about is, let me make that a little bit bigger. This whole complex here is that Liz Frank injury area, that midfoot sprain area. Now, when it's on the lateral side of the foot, on the outside of the foot, not as bad. But when it's between these two bones, and it could be, again, have all of these, then sometimes you actually have to do surgery for it. So it's a much bigger deal.
So we don't want to go on and on and on about this, but this is not an injury that is, not only is Cam use his feet and has just absolutely phenomenal movement, speed, strength for a guy his size. It's truly impressive.
Well, we said last week, we thought that this could easily be 4 to 6 weeks.
Absolutely.
Sure. And they probably rushed it to get him back for week 1.
Right.
So they shot themselves in the foot. They should have kept him out week 1, week 2, and then maybe he's back by now.
Exactly. Because this is another injury that's just hard to splint. I mean, custom orthotic insole, that's a real rigid insole that really protects that arch. Firm soled shoes where you put a steel sole insole with it. You could do all these things, but anytime you plant and push off the foot and rotate on that foot, you're putting stress right through that midfoot, and you're gonna be causing a lot of pain right to that area, and additional injury. So, I'm not surprised he's out this week. I'm not expecting him to be back next week, but we'll see.
And just before we move on, I love the reason why I got this question this week is what is a Liz Frank? Where did they come up with that?
I love this too.
Yeah, and it goes back to Liz Frank was the surgeon, the field surgeon for Napoleon's army in France, and this, if we understand it, as the soldiers would be in their saddle, the way this injury occurs is after they're thrown out of their saddle, their foot gets caught into the saddle, and as they're rotated out the stirrup. I'm sorry, you're right.
That's one way. The other way is get frostbite and trench foot, and it was called the Liz Frank amputation because that went right through the tarsometatarsal articulation,
which was easy for him to do.
Right.
So the fracture occurred coming out of the saddle and getting caught in the stirrup.
Right.
And the amputation occurred
back then.
Right.
So,
sure.
So that's one way. But they also got frostbite and trench foot that they would also have to amputate because of gangrene anyway.
So that was called a Liz Frank amputation.
So that became Liz Frank joint.
Did they still teach that when you were in medical school, Dr.
When I was a resident, we used to have fracture conference every Monday morning. Okay.
Uh-huh.
And it used to be called resident skeet shooting. All right. So it was usually the younger residents that were actually covering the ER, and they would go up and present every fracture that came in over the weekend or interesting fractures came in during the week. And so you would stand up there, and our mentor, Dr. Joe Zawatsky, who was a phenomenal surgeon, phenomenal mentor, but he was also a hard ass when it came to stuff. If you ever used somebody's name associated with an injury, Jones fracture, Liz Frank injury, Maisonneuve, all these kind of things, he would go, "Oh, who was Liz Frank? Who was Sir Robert Jones? Who was, and you know, oh man. And you learned real quick to research everything you could, superfluous around what you're actually doing to treat it, because they will just torture you about it. And you were up there just sweating, and you're like shaking, putting up real x-rays back then. You know, we actually put up x-rays back then. But I mean, now they're all images. But yeah, that was yeah.
I love resident skeet shooting.
Probably wouldn't be allowed to do that now. You know, it's a little harsh.
No, you'd hurt somebody's feelings and then you get in trouble.
And then have to go to a quiet room. So,
so moving into kind of our next injury that we haven't had a chance to talk about on the show yet, but I wanted to kind of get into, and that's with Deshaun Jackson. And the reason I want to talk about this injury is because this is where when we start using the term sports hernia, which it's funny now, when we were, when I was just starting in athletic training, the term was just coming out, and now the actual term sports hernia is kind of an old term, and I'm becoming more of a generic term. But what it's reported is that he has a groin injury and an abdominal strain. And those two things together are what made up the old term of a sports hernia. And the question about this is it bad enough that he's going to require surgery, which in all fairness could make it back by the end of the season if he did have to have surgery. But the sports hernia is one that I like to talk about because it's a very generic term, and each sports hernia is unique unto itself. If you want to kind of expand upon that, Dr. Palumbo.
Yeah, no doubt about that. I'm going to try to bring up another picture. So basically, these things, before we had MRIs, you would know there was, we would call it a groin strain.
Right.
So many times. And so classically, where what we call athletic pubalgia, sports injury, or muscular injury, that's called now, it becomes from the fight between the abdominis, which is the six pack muscles that insert into the pubis over here, to the adductors that bring the legs, the hips in. There's a plate. Howie, is he building a desk over there? What's going on?
No. What's going on?
Doing? Sounds like you're building a desk.
No, I'm not building a desk.
But woodworking is his hobby.
That's good. Well, do it when you're off the air. So basically, there's an imbalance of the pull, and there's an actual plate right here that can get separated from the bone. And when you hear the classic sports hernia or athletic pubalgia surgery, they're often talking about reattaching that plate or reattaching the torn muscle to this bone over here. Now, sometimes, and classically, this goes back and forth and in and out of favor. Sometimes they'll lengthen or release part of this to give it to lengthen it and to decrease the pull as well. But the most important part of the fixation is fixing this area. Now, having said that, it's used so generically right now, because now when we talk about core muscular injuries, there's a lot of structures in that area. There are many. The pelvis is an incredibly complex area when it comes to the pelvic floor, what attaches to the pelvic floor, what attaches to all the muscles around the pelvic floor, and even strains to those areas can present as what we call athletic pubalgia. And what really has helped, obviously, is the advent of not only MRIs, but very specific protocols for MRIs. And that has helped immensely diagnosing these injuries. Normally, if that plate is just, say it's inflamed or just partially torn, there's a lot of there's rehab that we'll want to do first. And it's usually addressing the imbalance, right, Howie?
Right. Yeah, you want to make sure that your strength is good in certain areas and flexibility is good in others. We talked briefly about surgery. Mark mentioned, he might be able to be back by the end of the season. I think when the surgery first started to be performed, the guys were rushed back. So I'm hoping that there's a little bit of a pushback to keep them out a little longer, because I think there's some NFL guys who came back in 2 to 3 weeks, and I think that's a big mistake. I've seen some protocols that have.
This really got popularized in hockey first. Hockey
right.
first, soccer second, then NFL, then basketball, and each one has kind of a different taste, different things that are the problems. And the problem was the surgery is done by a general surgeon. Okay, it's a general surgeon area, and they're not versed in what it takes to return somebody to sports. Is going, hey, yeah, this will heal in 3 to 4 weeks, 5 weeks, 6 weeks. He'll be fine. Go back. They don't realize what it takes to get somebody back. So they
right.
trainers, no problem, man.
Yeah, 3 to 4 weeks to go back to being a desk job.
Yeah, exactly. So, and that's where part of the problems came. Now we know so much more about not only balance between the abdominals and the adductors, but also the whole core, the whole all the obliques, all the hip mobilizers,
sure.
gluteus, the quads, the hamstrings. They all come in together. So you really have to pay attention to a lot of this. And also it's an area, there's a lot of things that happen in the pelvis and the hips and the groin area that can all cross over. You can have a labral hair in the hip, and a labral tear in the hip, and you think it's athletic pubalgia because of the way it presents. And the vice versa could happen. So you really got to take your time to really diagnose these injuries, or else you're going to be operating on something that doesn't mean to operate on, or you're going to be rehabbing through something that shouldn't be rehabbed. So, you really got to make that diagnosis.
Yeah, I mean, the other thing too with the diagnostics is, you have a pelvic obliquity where one side of the pelvis is asymmetrical to the other, and that could throw things off. So you could be, doing an exam and identify weakness that might be related to hip rotation. So I think that the key is fix what you can fix from a rehab perspective, as long as it's not too serious of an injury, and then re-exam and see really what you have.
No doubt. I mean, obviously, if you have a true avulsion, you
right.
get the MRI, you have a true avulsion. And quite honestly, this is one of those areas that we don't rush to get studies on in the general population. But any professional athlete or any high-level elite athlete, college athlete, we're going to get that study very quickly. And so we'll have a lot more information right away and
sure.
a lot more know what to work with. And the other thing is, just because you have one doesn't mean you can't have both. So you really got to look for making sure you're ruling out all the potential causes for the pain.
And this surgery got made very popular by someone right here in Philadelphia, but Dr. Myers, and he brought in years ago. I can't believe it feels like it was just a few years ago, but it's been a while. Brian Kelly, who's a renowned hip surgeon, and they kind of co-treat on this. And Dr. Palumbo, you could probably talk about, you had kind of alluded to it. A lot of times in these surgical procedures, it's not just going to be the hernia surgery, but you're going to need an orthopedic surgeon that specializes in hips to do a hip component as well as vice versa. Like you said, sometimes in the diagnosis of it, it might just be a hip injury, and then it might require a hip surgery.
Well, it was funny. I was just at the FIFA and MSL sports medicine meeting down in Miami last weekend. And one of the things that we're learning is, it's not only why is that the fact that they can occur together. It's like why they occur together. And one of the biggest things that has come out, and I'm sure anybody who listens to ESPN knows these terms. I mean, we're talking about hip impingement. Okay. So what happens is there's a bump on the neck of the hip bone as it leaves the socket. And what happens is you have a bump, and that comes out. That bump is not only going to hit against the socket, but it's also going to torque. And like Howie said, it's going to tip. That there's the pelvis is like a ring, and in the back of the ring you have the two sacroiliac joints. In the front of the ring you have a pubis. Well, if you can actually torque it by putting too much stress on the hip, so you could have the reason to have this femoral acetabular impingement that we talk about and the labral tears that we talk about, but also have the problems with the athletic pubalgia or core injury. So we're learning, as we go further, we're learning more and more. And so it's one of the best things about sports medicine, as you guys know, is that we're always learning, and we're always
Absolutely.
more stuff out. And it's so often the case that from sports medicine we learn more about things to take care of the rest of the population, because you tend to push the envelope. You're getting studies early. You're just learning a lot more, which is one of the reasons why I love sports medicine in the first place. But yeah, it was really interesting to see see everybody talking about it at the meeting this weekend.
And the larger issue, and this is really with all athletic injury, but when we talk about prevention, part of our job, Howie and mine as preventative injury, evaluators, is that we're looking for, the term, and this is the first time we've used it on this podcast, but you'll hear us say it many, many times going forward, is the term movement dysfunction. And what does movement dysfunction mean? Movement dysfunction is a gross term that literally just defines, are we moving properly? And you'd be surprised how many professional athletes are not moving properly and are not training properly because they have poor movement patterns. One of our colleagues, Brian Camerato, who we hope to hear from on this show in a week or two, this is conversations that Howie and I used to have all the time together. Is you're under the impression that a lot of these professional athletes move properly and they're highly trained and they go see this specialist or this guru, or they have this trainer that works with them in the off season, and they spend hundreds of thousands of dollars a year doing that. And in reality, Brian, who used to work in the world of professional baseball, used to talk about how many catchers that they would get that literally could not squat properly. And
Absolutely.
It's
right.
kind of important to be able to do that at that position. But if you're not able to squat properly and the right muscles aren't at the right length and the right muscles are not firing in the right timing pattern, you're putting yourself at greater risk when we load those muscles up in an athletic position. And a lot of times these injuries, athletic pubalgia, sports hernia injuries occur because of muscle imbalances and poor movement patterns.
I think really the bottom line for this is that you have to have a good team, in order to diagnose, do surgery or not do surgery, and then complete the rehab and get somebody back on the field. I mean, from all the things that we're saying, there's got to be good coordination.
No doubt.
I thought by good team you were just taking a rip at the Eagles. If you play for the Dolphins, you're destined to get hurt this year. If you play for the Patriots, you're probably going to be healthy all year. So,
well, you know what? If Bill Belichick is in charge of telling you what's on the injury report, everybody's healthy or everybody's hurt. It depends on the day and what the hoodie tells them.
But we know Brady's not. He's not unscathed this year. So
no.
Yeah, listen, he spent a record number of weeks on the injury report with a shoulder injury that didn't exist. So I don't believe anything that comes out of New England.
Years.
He spent like 42 weeks in a row with a shoulder injury on the injury report.
Yes. So, now he's just an amazing athlete, with those kind of injuries.
TB12.
Yeah. So, again, we talked about, let's get back. I just want to get back to one more time of that. How many times do we screen these athletes, either preseason? And, you guys remember when we used to do all the baseball screenings and then the movement screenings and things like that. these studs would come in looking great, and then you test them on a single leg squat that they couldn't even hold their balance, or you have ballerinas that that their ankles are so weak that you can't believe it, and they but they could dance and they could do everything, but they're getting hurt all the time in other ways because they have deficits further away from the injury than you would expect. So you really, we're getting much better in treating the whole athlete. It's still slow coming. I mean, if you, like you said, even these great trainers that take care of these professional athletes, a lot of times they have their own patterns of what they want to accomplish, and they don't necessarily look at the whole athlete themselves.
Well, I think one of the bottom lines is that if the more coordinated you are and the better athlete you are, the better cheater you are. So you can compensate more easily. You use other muscle groups. I mean, take a look at some professional football players. You look at their lower backs, and they have that hypertrophy into their paraspinals. That shouldn't look like that. That's because they're not firing their glutes properly, but it looks like look at this big muscular guy. And I look at it and say, he's at risk for a back injury, and he probably wakes up every day with a stiff back, and he's only going to play 8 years instead of 12.
Right. Exactly.
The other example is that swimmer. The swimmers are, the swimmer's body, with that huge, with that six pack, and then all of a sudden you look at some of them, and they have this rectus that is just, it looks like it was surgically implanted in there. And what that says to me, as a clinician, is this person's going to have a history of shoulder injuries because they have a complete core imbalance, and they're always going to be in a poor posture position while swimming. And, this is going to be an eternal shoulder injury for me, for anybody working with this individual. So that, it's funny how the lay person looks at the athletic body or the beach body, and then how we examine that body as well. And how you kind of alluded to it as well. You look at that hypertrophy of the low back muscles, what that says to us, first of all, and this is a great time to talk about it, this person doesn't use their glutes at all. And why are the glutes so important in what we do? And this is probably a great time to talk about glutes, because, it is a joke, and, the term glutes, it does make you laugh in our childish ways.
Believe me.
But, why are the glutes so important?
Well,
first it's the largest muscle in the body.
Mm-hmm.
And for somebody who's had back problems since his whole adult life, I know how important it is to have those glutes firing well to stabilize your back, and how you can explain more about that. But it is an incredible difference when you're having back pain to, squeeze your butt muscles, and immediately you'll feel better. Obviously, they'll start burning like crazy because you're probably very weak in your glutes. But once you really stabilize those glutes, it can make a world of difference.
Well, most people that have chronic back pain, they can't even do a glute squeeze. So laying on your back and tightening your butt muscles without tightening every other muscle in your body, sometimes I'll get people and I'll have them do it, and they think I'm crazy. I remember I had a patient maybe 10 years ago, and I challenged him to, he's like, nobody can do this. And he went home and he said, I went home and I talked to my 85-year-old mother, and she could squeeze her glutes. I said, well, she probably doesn't have chronic low back pain. And he said, you're right. And, and I think that, the timing of the glute contraction is also important. So some people tighten their glutes. It just happens after they've already tightened their lumbar paraspinals and their hamstrings and compensated with their hip flexors. And then their glutes come in and fire. And it's a little bit too late because you're stressing all those areas. And then you're having tight hip flexors, you're having overstressed lumbar paraspinals, and those lumbar paraspinals are there as a support structure, not to provide the body with power, right. And I think that's where in a professional athlete, you're gaining your power from those glutes. I mean, look at the best basketball players. They have big butts, and they gain power from them. Their jumping ability, that all comes from their glutes.
Exactly.
My favorite core movement pattern are the calf squeezers. The ones that actually have no ability to contract their glutes or even their hamstrings, and you tell them to squeeze their butt, and they just squeeze their calves.
Right.
And
and their calf muscles are huge.
They look like Popeye.
And they look
Yeah.
at you crazy, like you're not. Who can do that? You're crazy. Who's supposed to be able to do that? The reality is, no. You're supposed to be able to squeeze your butt when you ask your butt to squeeze. You're not supposed to contract your calf muscle.
But let's talk about that movement pattern, because there's a lot of people out there like that. So what they're in essence doing is they're pushing off, they're plantar flexing their ankle, and they're working their calf with every step because they don't have good stabilization up at the pelvis where the glutes are. So I mean that's a classic overcompensation. But people will look at it like, oh, look how muscular my legs are.
This is a good test for everybody out there. Tomorrow or tonight when you go up to bed, or tomorrow when you're climbing the stairs, if you're a stair walker and not a cheater like me, when you get to the top of the staircase, what burns? Do your quads and your hamstrings burn, or does your butt burn? Because if your quads burn, then you're not using your glutes to propel yourself up the stairs. So think about tightening your butt as your foot hits the step and using your butt to propel you up the stairs.
If nothing burns, then you're in good shape.
Yeah, there you go. Yeah.
That's right. If you can't breathe when you get to the top.
Go see your cardiologist.
or your physical therapist.
Yes.
We need to work on some strengthening.
I would start with the cardiologist if you can't breathe.
That's the most important
thing. Then go to the physical therapist after that.
Good call. It might take 911 though, depending on the level.
Or that.
Doctor says you're going to die. No, just kidding.
So, moving forward, it's just a good lesson in movement dysfunction and movement patterns, and assessing those as it relates to injury. And we know that knee injuries, ACL tears, we have objective data as we've started to compile years ago in female soccer players. Is one of the most studied areas for ACL injury, but we know that poor movement patterns and things that we can preventatively assess allow us to provide programs for those athletes as we head into their seasons and as part of their off-season and in-season training. We do understand that glute medius, which is another muscle that is important in the core. We always talks about the maximus because it kind of bullies its way over top, but the glute medius is an extremely important muscle that creates stability. And what happens when the glute medius is weak is we get increased medial knee strength, which creates increased stress in rotational injuries and could lead to more ACL tears. So that is an objective, that's been studied at length, and we do know that that's an injury that occurs. So when we mention the core, people don't really understand what your core is. Right. And a lot of time it's not just weakness, it's timing. And that's why we put so much emphasis on it, because these gross orthopedic injuries, such as ACL tears and ankle sprains and shoulder injuries and, elbow injuries and pitchers that occur are due to a decrease, either timing injury or a weakness through some of the core musculature or most of it.
And the core is not just your abs. The core is your hip girdle.
No,
actually, the abs are very, very
right.
Are the most overtrained muscle group in the body.
All right, but they look good. So
yes, well, some, not mine, but
when they're not hidden.
Some people's abs do. Yeah. Some people's abs look like you've been eating cheesesteaks for an eternity, and that would be me. So
I'm going to take that personally. So again, like I was talking about, we were at the soccer medicine meeting this weekend, and I'll tell you, one of the coolest thing that we saw was that FIFA and MSL and NWSL all keep a lot of great statistics, and now a lot of the colleges are keeping great statistics as well. Just implementing FIFA's dynamic training session, the 20-minute session that they like to get, especially women athletes, but all athletes at the beginning of practice. When they do that for at least 25 to 30 minutes, 3 times a week, they decrease the amount of ACLs significantly especially in women. The amount, I mean, so just these developing these movement patterns and doing them and training them throughout the year, continuously. That it has been shown that it's like so important. It's so stupid not to do it because we know what the injury prevention is. I mean, it's like 300,000 ACL injuries a year, and so if you could take 5%, 10% away, that's an incredible amount. That's an incredible.
I think that you're probably right. What's lacking is the movement prep prior to activity.
Exactly.
I mean, I see a lot of shoulders for rehab in probably 50+%. And when I have people that are done, they ask me what to do. And I usually tell them, take the exercises I gave you. They're not meant to be used with high resistance. Use them as a movement prep. Do what I've told you so you're getting neuromuscular activation, so your brain's firing the right muscles, and then go lift your weights. Then go play your sport. Do what you do after that. But that's where the utilization of the rehab piece, I think, fits in the best. And in the case of this, soccer players, activating glute medius, like Mark said, because then that keeps the knees in a neutral position, and you don't get into that valgus position, that knock-knee position where you're more at risk for an ACL injury. So that's probably what they're doing is movement prep to get the glutes fired, get moving properly, and that makes a whole lot of sense to me.
And obviously, I mean, and the other problem is there's not, these athletes, should be started to be screened, before every season, and no matter what age, you could teach the person how to land, so they're not
right.
They're not going knock-kneed when they land, or they're not landing improperly with their knees straight. All these things are important to train, and they make a huge difference when it comes to injury prevention, especially knee injury and ACL prevention.
I think the other thing too, that the factor is that some of the youth coaches might identify that that's a problem and see that it looks funny, but not know how to correct it. But I think that they just need to be aware and then bring somebody in who can say, all right, this is how we correct it. This is how we retrain it. I had a kid recently who was, I think, a pretty good soccer player, but he moved horribly. And I said to mom, I said, okay, we're dealing with knee pain right now, anterior knee pain. I'm going to see you in 2 or 3 years if we don't fix this with an ACL injury. Exactly. So this is what he's got to do moving forward. And if there are any issues, please contact me, because I don't want to see. I mean, there's plenty of people getting hurt. I don't need to see them. I'd rather prevent them and not see surgeries if possible.
No doubt.
And this is definitely going to lead into, and we, saving this topic most likely for next week is kind of borders now into the overuse injuries in youth sports, and kind of what the academy programs and what these club programs have done now is increase the amount of exposure that athletes can have to overtrain themselves, but then also not give them a proper rest period, and then put somebody in front of them that's coaching them that doesn't understand movement dysfunction, that doesn't understand movement prep, and that recipe is a recipe for disaster. And we see that all the time.
Ball handler, the greatest dribbler, the greatest, and you could be the first one hurt.
Yes.
Sure.
We develop so many sports-specific skills without developing the actual sports injury prevention skills and movement skills and things like that. And it's a big problem. It's one of the problems with single sport specialization, which we will get into in another podcast. But it's one of the problems with 9-year-olds and 10-year-olds playing one sport year round, 2 teams. They never get a chance to rest. They never get a chance to develop good movement skills other than sport specific skills. And so they may be very talented or very capable as a player, but their chance of injury is very high.
Or they might not be good as a player because of that. I mean, they might not have the opportunity to develop. I know that bringing up Urban Meyer is probably not the best person to bring up, but I remember seeing on his whiteboard, he had football players in one column and athletes in another of who he was recruiting. And I think there were 3 football players and 35 athletes, because that's what people are looking for. They're not looking for the kid who plays football all year round. They're looking for somebody who moves well And in order to move well, you have to do different things.
Exactly.
A big misconception among college coaches, and we all know people that coach at the collegiate level in a variety of different sports. Football being one of the biggest, and you can tell you right now, major college football coaches, even the Division II and the Division III coaches, they are looking for well-rounded athletes. I saw a statistic: the starting offensive line at the University of Iowa right now, all former wrestlers. Every single one of them former wrestlers. Most of them, if I'm not mistaken, I don't want to quote myself without pulling a statistic, I think they have 2 or 3 state champions, all of them all state wrestlers, and they actively recruit them. I know that when I was at NC State, our coach was Chuck Amato at the time, who himself was an ACC champion wrestler and a linebacker at NC State, used to recruit the heck out of dual sport football players and wrestlers to play both offensive.
Doesn't everybody in Iowa wrestle?
I think they wrestle and they farm. And those are the 2 things. So we're gonna get letters from Iowa.
Hope so.
But yeah,
I think we're up against it.
I was gonna say, do you believe we've been on the air about an hour and 15 minutes?
An hour and 50 minutes. So
yeah.
For those of you who aren't that are listening to this on our replay, don't forget you could still ask us questions and in the comment section. If you ask us questions there, we will answer them next week. I promise you that. And I just want to thank Howie. Always great to see you, man. It's one of the best therapists I know. He's at St. Luke's physical therapy, and he's there. We have a lot of great therapists, but he's one of the best. And Mark, even though you're not doing athletic training anymore, you were one of the best too. So it's always great to have you here, and the profession misses you, but we all understand why you're not there right now.
That's true. We'll get into that because we're going to be talking about a lot about athletic training in the next few months, and we're going to have some guests on that are going to be able to celebrating that with us.
That'll be great. So everybody, we'll see you next week. Again, look for our announcement. I'm sorry I didn't put any announcements out this week because I wasn't really sure what day we were going to do. We'll get better with this as we go. This is a work in progress, as we say, but we'll be back next week with the OAA Sports Medicine Foundation Sports Doc. And thanks for listening, everybody.
Bye, everybody.
Good night.